So we're going to start with Deanne. There's a microphone. Great. These are short answers. I'm going to emphasize the short answers because I'm going to cut them off if they start waxing long. Okay. Well, there may be some new people. I have been on 5 to 10 milligrams of prednisone for RA for the last 7 years, including Remicade and Arava. What are my risk factors of earlier death?
Well, is this on? Yeah. So, I mean, when we looked at this dose threshold, the 5 to 7.5 milligrams was the lower dose that showed that this might actually be the safe dose. So, I think your risk of death, this is probably let's remember that a risk factor is only one of many things that influences your risk. So, because you have one risk factor does not mean that the outcome is necessarily going to happen, although I suppose we all eventually die, but I mean earlier. So a low dose is a lower risk, and if it keeps your disease under better control, good control of the disease is also something that's a good risk factor. But you might want to discuss with your rheumatologist whether it is possible for you to try to get off the prednisone.
Thank you. I hope she was going to get there. I hope she was going to get to discuss it with your rheumatologist.
Get on appropriate DMARD therapy.
And the next one, we've got lots of these, is giving a heavy dose of prednisone for a short term still dangerous?
So what we looked at, this is a very good question. What we looked at is not giving it for short periods of time. It was people who are on it for over long periods of time. So we don't know what the effect over a short period. So what I showed you was for people who are on it for long periods of time.
Great.
And you have to weigh the reason for which you're given a high dose. And the reason for which we give high doses are often also reasons that it may increase your risk of death or severe outcomes. So I don't want you to just look at the data I've shown you. You have to weigh pros and cons, and you have to look at both sides of this equation.
Thank you. There's also the Europeans believe in using a high dose for a very short period of time, and the disease control, and that has a positive benefit on disease control. So I think probably high doses for short term are not the same thing as taking small to moderate doses for a long time. The next question, we have two rheumatologists, so I'll let them both give very short answers. Dr. Lakai, why are rheumatologists still prescribing prednisone if your results are so bad, damaging?
So there's a lot of controversy within the rheumatology community about prednisone. And as Dr. Isdale alluded to earlier, there's a belief that if you use the prednisone early on to suppress the disease, that this may have good long-term outcomes in terms of getting things under better control because you eradicate inflammation, and you've heard inflammation is bad. So there's a lot of unanswered question. I've shown you results of one study, and there are different schools of thoughts on prednisone.
Now, I would like to compliment that the rheumatologists are not the only one involved with arthritis care, and often we have patients referred to us already on prednisone. And prednisone can make you feel really good. So sometimes the challenges of the rheumatologist is how can we decrease or stop, minimize the prednisone exposure.
And maybe the only other thing is why are rheumatologists why are you given the prednisone? So I just want to re-emphasize that. I don't want everybody walking out of here stopping their prednisone, because you usually or often, especially in diseases other than rheumatoid arthritis like lupus, the prednisone is given for life-threatening manifestations of the disease. So be careful, and I certainly don't want the take-home message to be that prednisone is uniformly bad.
This is the benefit of sitting in between the microphone, is you get to grab it. It's like Pac-Man. From the patient perspective, I've had rheumatoid arthritis 30 years. I have a bottle of prednisone sitting in my cupboard, and when I need to be really great, my rheumatologist and I have a contract, and that is take pulse dose if I'm going to be flying, if I have a huge weekend, if I want to go dancing till my feet fall off. I know I can use that safely as prophylaxis to do what I want to do in my life. So I think you need to...
How much?
2.5 milligram tablet. So it's like a heavy-duty Band-Aid. Doesn't replace my DMARD, my disease-modifying drugs, which are the most important thing for me to be taking. But so I just wanted to throw that on behalf of Kelly and I. Yeah.
But it's a contract, and it's a contract. I come off it right away, but it does enable me to do things that sometimes you need to do.
Thanks for letting us wait.
Yeah, I'm looking at the table. I think it's okay. I'm looking at Deanne's data, and I think 2.5 milligrams every now and again is fine.
That's why that dose threshold is so important. So I think 5 and anything under 5, you don't need to worry. Don't lose sleep
A
over it.
final question for Dr. Lakai, but it's not the final. I'm just not giving you all of hers right away. You know, as I said, death is a fascinating thing. And the only thing that's close to that is heart attacks and strokes. Dr. Lakai, I have heard that some of the medications for rheumatoid arthritis are contributing to heart attacks and strokes. Will this relate to early mortality?
So definitely heart attacks and strokes contribute to early mortality, because that's what I said is the leading cause of excess risk of death. However, the data on medications used to treat RA, the disease-modifying agents, actually the data is actually reassuring, showing an increased risk of heart attacks and strokes. So methotrexate is shown to reduce the risk. Anti-TNF agents, biologic agents, seem to reduce the risk of heart attack and stroke. So prednisone is the only one that's been shown to increase the risk of heart attacks and strokes in prior work that's been done at ARC.
Just to complement, some of our colleagues in cardiology are looking at methotrexate in the general population to reduce risk of cardiovascular disease. We don't know the results of these studies, but that's only fascinating.
It's in high-risk patients.
Yes, right. So people that don't have arthritis but have a high risk of heart attacks, they're trying to see whether giving them methotrexate reduces the risk of heart attacks.
There's several $1 million put into arthritis research by the feds every year. This study on methotrexate in the U.S., they've budgeted $130 million for. Now, Dr. Fortin, when do you anticipate My Lupus Guide to be available for people to use?
Yeah, by the second half of 2018, it should be public. The only reason why it's not currently public, because it's all done, and by the way, it's bilingual, there's a French version, is that right now we still want to study and learn from it through that CIHR grant. So we needed to restrict it to the centers that will be using it, Vancouver being one.
Okay. A general question for everyone. Someone asked, will the slides be available? I will make one comment that anything that's not being published probably won't be made available, as soon as you put it on the web or something, you lose all of your rights to it. But is there
No problem.
no problem?
No problem.
You may have to, Diane.
We might
Okay,
have to modify some
Diane
of the
may have to
slides. Some
remove
of
a
this
few
was
slides.
hot off the research results, so we might have to modify the
Yeah.
slides a little bit to
Yeah.
allow us to not lose.
Diane may have to remove or alter slides. Yep.
Same for me.
Okay.
No problem here. Some of the research I presented today was published on October 6th, so it's fresh off the press, and you can access it online as well.
I checked with Valley Village and all the other thrift stores and my sewing room, and you may use them.
Cheryl, are you going to make Walk 10 Blocks available for Android?
That's a very good question. I think probably the way to get to the most people is to have a web-enabled app. So it's web-enabled, meaning it can live on the internet but be downloaded to any smartphone device, whether the platform is iOS or any other smartphone capability. So that is the end game. If, in fact, the research results tell us that it was actually used and that users engaged with it in a meaningful way and made a difference to their activity levels. There's no reason to spend money to make something available unless, of course, the research proves that the theory was correct.
From a patient point of view, It doesn't matter what you use, whether you use that Fitbit or you use that Walk 10 blocks. We don't want you to wait for those apps from a patient point of view. We want you walking. We want you up every hour. So until they come out, when they come out, it's going to be easier. But until then, start doing it.
There you go. Do what she said.
Yeah. Just out of interest, the walk 10 blocks is what, like 3,000 steps?
Yes, approximately.
Yeah.
I think it's like 3,300 or
So
something
if you
like that.
have a pedometer or any other thing, it's
Yeah.
about, the walk 10 blocks is about 3,000.
Or how
And-
many times around the track? How many city blocks? Excellent.
That's like, what color is an American greenback? Okay, this question is for Linda. Was the disease active during the Fitbit research? Did the disease get worse or better?
Good question. I'm trying to think what the result was. So in our study, we didn't have enough people to actually show that there was a difference. However, in the larger body of research, it does say that if you're more physically active, it's good for your disease activity, so you're supposed to do better.
Good.
As well. I did both of Linda's studies, and in my first one, I was fairly stable, and I actually increased my steps dramatically, and I kept there for a long time. In the second one, I was in a severe flare, and yes, mine did decline, but I had gotten the information, used the information, so that when I came out of that flare, I could continue on.
Dr. Lee, will you continue to follow the group past 6 months to see what happens long term?
Not in the Monitor OA study, but the one that we are recruiting right now, and that's why I encouraged you to talk to one of us when you finish, if you're interested. We are doing one that is following people for a 9-month period and beyond
Thank
in
you.
osteoarthritis, lupus, and rheumatoid arthritis.
We tweeted about it earlier.
Thank you.
The interesting thing is the death is interesting and movement is interesting. Dr. Lee, how is it determined if running on an OA knee is advisable or should be avoided? If it should be avoided, what are the better options?
Can you repeat the first part?
So,
Sorry.
is running on the OA, if you have OA of the knee, is running advisable or should one avoid it? If you should avoid it, what are the better options?
Well, it depends on, well, OA exists in a continuum. You know, sometimes it can, at the early stage, oftentimes the most important thing is that you have good shoes, good gears, and good warm-up before you go out for running. So it's not necessarily that if you have osteoarthritis, you have to stop. But of course, we were talking about the later stage of osteoarthritis, where even walking or getting up from a chair hurts your knees, you may have to look at other options. And one of these type of options would be exercising in the pool, which is much easier. You can still walk fast. You probably cannot run in the pool. I don't know, Cheryl, do you run in the pool?
You can run, but it doesn't look very pretty and it's not fast.
But you can still do quite a bit of work, and
Yeah.
your heart and lungs and
Yeah.
your muscles.
And stationary cycling.
Stationary bike.
Okay, this is
Cheryl
sort of a
said.
little redundant, but I think it's a big topic, so I'm going to ask it again. What are your thoughts on running if you have RA, Dr. Lee?
That is another good question, and I think it all depends on your the symptoms and how active your disease is. Generally, we don't ask people to stop doing things that they are able to do. And as a physiotherapist, I oftentimes explain the two types of pain. You have good pain and bad pain that you can monitor. The good pain is that when you try something new, the area above and below the joint, your muscles, are hurting. So that's probably a good thing because your muscles getting used to the new activity. But if the pain happens inside the joint and it lasts more than 2 hours, you probably have overdone it. You need to scale back.
When I was diagnosed, I was basically told to just rest, be careful. I was an Olympic athlete at the time. So imagine hearing that. And a lot of people, whether you're an Olympic athlete or a recreational athlete, the shock to the system, to your psychosocial, psycho-emotional state is significant. I actually ignored them. And I kept sort of just doing what I could do when my disease allowed me to. At the time, there was no research. Today, there is actually quite a big body of research that says even high-intensity exercise is not harmful to rheumatoid arthritis. So you have to keep doing. It's the if you don't use it, you'll lose it sort of principle. So I'm not a physician, I'm a health educator and a person living with the disease, and I'm just here to tell you that you have to keep trying to do what you love to do because it's a significant part of our overall wellness.
Okay, thank you.
Sermon
now there's a
complete.
question for John. I don't know, I didn't say anything. I was trying to be very quiet. In your opinion, what has been the biggest advance in research since founding Arthritis Research Canada, Arthritis Research Canada? Well, we have 70 people involved in 75 projects on a great many diseases, and so that's kind of a hard question to pick out one project. At a very high level, I think a lot of ARC research is directed towards focusing on early diagnosis, whatever the disease, educating the patient so they are going to perhaps feel more control over the disease and want to get better. They can learn what can be done, actually intervening often aggressively, as you heard from Dr. Lakai, but also in things like osteoarthritis of the knee, in totally different type of diseases like gout. And that seems to influence outcomes, and some of the outcomes that we're now trying to prevent, you've heard about: death, heart attacks, strokes, lung disease, hip fractures, cancers, I may have forgotten, infections, all of which occur, and that's our current focus. And work disability, which is in fact, thank you, the biggest cost. That's the trouble, we're trying to pick one. Okay, so I think I've done my only question, and I hope I'm not accepting any more. Now, this could be, I'm not sure, Kelly, if you're the person, where do you obtain information about participating in future studies?
There are a couple places. If you're on Twitter, you do go on to, do friend us, and that helps. We quite often will pass it on for there. The best place, though, is to continually look on that ARC Research, or Arthritis Research Canada webpage. It's really easy, www.arthritisresearch.ca, and there's a section there for upcoming research projects. There's also all the videos that have happened at ROAR. There are also information about different events that are happening. There's always information on our one major fundraiser.
Okay, go to the website for future studies, all right?
Or ongoing.
All ongoing, yeah. That are open. Ongoing means that they're open and available for you to join. Oh. Yeah, there you go. Good point. No one asked me how to do that, but you can do it through Arthritis Research Canada website. We've got lots of questions left. Paul Fortin, your model on personalized centered care, is it currently available in British Columbia?
No. The personalized, we have to make a distinction because this is often used, personalized medicine or person-centered medicine. So I'm talking right now for lupus. The difference also is there's also often confusion. In pharma, people will use personalized medicine to maybe find the best drug that suits you according to genetic studies.
This is a yes-no question.
No.
Thank you. All right. Cheryl, where did you find participants for the Walk 10 blocks research? Are they all RA patients?
Where do we find them? So we have about 40,000 members across the country, French and English. Our partners, Alzheimer's, the Alzheimer's Society and the Canadian Association of Retired Persons, or CARP, ARC, basically our network broadcast news of the availability of this study. And if you had an iPhone, you were able to enroll.
And are they all RA patients?
No.
Thank you.
Was that the original question?
Dr. Hamilton, that's it? Thank you. Dr. Hamilton, this is a tough one. What has been the greatest surprise to you in engaging patients in research? So you've got to realize the greatest. We're not going to have 5.
It's a very good question, a very difficult one to answer as well, because it has been an overwhelming positive experience and a learning experience for me as well. Coming from a PhD, I didn't involve patients as research partners. So I think the greatest thing is the learning experience and being able to learn with and from the patient partners.
Great. I think that's a very interesting answer, not one commonly heard. Thank you. Linda, will continuing to exercise slow down my recovery from knee pain?
Slow down the
Yep,
recovery
that's the
from knee
question.
pain. No, I think it's the other way around. It actually
Okay.
will speed it up in huge body of research. But you want a yes/no answer, right? So.
Okay, Linda, if you run and you experience knee pain, is it worthwhile to try to get an X-ray to determine the state of your knees?
I'm not sure the X-ray is going to give a lot of answer, to the source of a knee pain, but I think having your knee assessed by someone understand osteoarthritis, by your rheumatologist, by a physiotherapist, someone understand osteoarthritis may be able to tell you what the source of the problem is.
Yeah. I mean, there are sports medicine people, physios, lots of people who, someone should probably try to figure it out, but you don't necessarily need an X-ray, even if you have early osteoarthritis, very early osteoarthritis, your knee X-ray at a research grade reading will be normal in 50%. Dr. Lee, that's an Arthritis Research Canada finding. Do you have concerns about the potential for abuse of privacy and human rights related to widespread use of technologies such as wearables?
Yes and no.
That's okay. You're allowed to have...
Am I allowed to
Yeah,
elaborate?
that's okay.
I need to ask for permission for that. Well, yes, in the sense that we all know that commercial wearable devices, they collect your information, it go to, a place, like for Fitbit, it will be somewhere in California in their network. So there is always important to know where your information is going to and how it's being used. In our study, we actually simplified the privacy policy of Fitbit and explained it to our participants. So in terms of our project, we have no concern about in terms of how the information is being collected and being used, because we use it in a very limited way, and also we explain to individuals how the information transfer is like. So if you don't agree with how the information flow is going to be and who has ownership of the information, you don't have to participate. From the UBC ethics perspective, we get full approval for doing the project.
Okay, thank you. Dr. Lakai, is the cancer risk in RA patients increased more due to the medications or the disease itself? If it's the disease, why and how? So this is a PhD thesis that she just gets a brief answer to.
So it's a very good question, and there's a lot of discussion around that and a lot of studies around that. So first I'm going to address the increased risk due to the disease itself, and the studies overall, when you look at the overall body of literature, seem to point to an increased risk of lymphoma. You ask me why. So lymphoma is a cancer of the cells of the immune system. Rheumatoid arthritis is a disease where the immune system is overactive. So it's thought that because the immune system is overactive, some of that gets dysregulated and it increases the risk of lymphoma. Lung cancer has also been found to be increased, and it's thought probably to be due to the link with smoking. So smokers are more likely to get rheumatoid arthritis, and smoking also increases the risk of lung cancer. The medications is a little less clear. It's very hard to evaluate the medications because there's the underlying increased risk with rheumatoid arthritis, and that people who have more severe disease are more likely to be prescribed certain medications. The biggest concern was with the anti-TNF agents, which is a class of biologic agents. And there again, the studies are not all that clear, but certainly that increased risk that we were all really worried about when the medications came out doesn't seem to have borne out in long-term epidemiological studies. If people already have cancer, it affects your ability to regulate cancer. So people who've had a recent cancer, it can increase the risk of it coming back. But new cancers, other than cancers of lymphoma, again, where there may be an increased risk, the other is cancer, the risk isn't as worrisome as we had worried about.
So I think you don't have to worry a lot about the drugs. That's the answer. Certainly not hydroxychloroquine, sulfasalazine, methotrexate, or anti-TNF.
And some of those drugs are used to treat cancer,
Right.
like methotrexate.
I'm coming back to the slides being available, and we have Mira Galperin in the audience, who runs all manner of things communicative. She probably should be here because I'm not that good at this communicative bit. But would it be fair, Mira, to say that the slides will be available on the website in, say, a week?
Well, I think the videos will be available on YouTube, I think about 2 to 3 weeks. Yeah, 2 to 3 weeks.
2 to 3 weeks, the slides and YouTube videos will be available. Okay, so that, yeah. I can't hear you.
Posters.
Oh, I see.
Requests for the
Okay.
posters to be posted somewhere or emailed to the online participants because they're flashed
online.
on the slide deck. for a
Okay,
very short
thank you.
time.
So 3 weeks at the outside, or you can email Mira Galperin, mgalperin@arthritisresearch.ca. That's great. Do you have anything else to say, Dr. Lakai, on infections, heart disease, or cancer that you didn't say?
Well, there is lots I could say, but I don't think I have enough time.
Okay. Here's an interesting one for Dr. Lakai again. Has anyone studied the risk of death in people with rheumatoid arthritis who have conventional aggressive treatment and people with RA who opt for alternative therapies?
I'm not aware of any study that has looked at that.
The interesting thing is, of course, alternative therapies are, if you look at people who are getting aggressive therapy and people who are getting no therapy, my guess is that alternative therapies, if anything, would be used even more in those not on aggressive therapy than those on it, but probably, if nothing else, the same. And those getting aggressive therapy are much less likely to die than those not getting appropriate treatment.
Yeah.
So
So
I
that
believe
one
that
half
if-
of this has been looked at, and that's the aggressive therapy, and that's been shown to improve mortality. But I'm not aware of studies of complementary therapy. But what's important is that complementary therapy not replace adequate treatment with medications that have been shown to reduce the risk of mortality.
I may not get to it, sorry. Does the dose of methotrexate affect mortality?
So there was a study that did look at that specifically, and there did not seem to be a dose-dependent effect or a duration other than as long as you've used it initially sort of long enough to stay on it, then the dose didn't seem to make a difference.
Dr. Lee, 20 seconds max. Were the people in your OA Fitbit study on any medications?
Sorry.
You have 20 seconds to
Were,
answer this.
were they on pills?
Patients on medications, the ones in your Fitbit?
Some of them did.
I don't think we broke that. Thank you, everyone. We have 20 seconds to spare.
Online? Okay.
Oh, too late, I think.
Just a few questions online. The first being, looks like it might be from a practitioner. How do we convert or translate all this research works into practice, especially among clinicians worldwide?
Why don't one of you make a clinician? I'll answer that from the patient perspective. So part of that is actually translating it into knowledgeable, like language that's accessible to people like us in this room. So there are organizations and groups in this room, such as APAB, such as ACE, who spend every day, all day doing that. So it's actually not just about getting guidelines in place for physicians, because I think John's told me for years that guidelines actually don't really change practicing behavior. So you have to power people to understand what kind of care and treatment they should be receiving so that they also help drive the care bus, so to speak. Now you guys answer from the doctor's.
20 seconds.
I think the other thing is to make sure that arthritis is on the map of chronic diseases as much as cardiovascular disease or cancer, and that resources are invested so that the services that the arthritis patient needs are available.
What we're going to do with the online questions, the supreme boss here is giving me hand signals, is that we are going to have the individual online questions sent to the relevant speaker or the most relevant speaker to answer online, because we are through the question time. So John, thank you very much. You are released.
There's a good example of the pot calling the kettle black. John Esdale is actually the supreme leader. And I would like to thank Dr. Esdale for doing such a fine job of moderating this forum. And I think it's very important to congratulate all of the wonderful speakers for their talks and speeches this morning, but the way the panel was handled was wonderful. It showed completely how the Arthritis Patient Advisory Board interacts with research scientists and vice versa, and it's a very, very important thing to show the importance of the role in patient treatment and patient interaction with the scientific community, as well as with the rheumatologists and physiotherapists and all of the other people involved. So I'd ask you to please give another round of applause to all of our outstanding speakers today. That concludes our formal presentations for ROAR 2017, and it's now my pleasure to introduce Shawneen Kellner, the Executive Director of Arthritis Research Canada, to say a few words on behalf of ARC. Shawneen.
I'm going to be really quick because John will probably shut me down because he's getting hungry, I suspect. So, in response to the questions, we've just had a really good input, and that is, I think the online questions we can take this week, and so I encourage you to join up to our Twitter account. So we'll get those going with Mira back there, and she can tweet out the answers. She'll contact the scientists and patients and see if we can answer those for you online. So please join us on Twitter, Facebook, and we can see how many questions we can get out in the next week on those, if there's anything that hasn't been asked. My job today is to say thank you, and that's very easy. First of all, I have a big thank you to Merck for their educational grant and Novartis and Abbey for their sponsorships. Without those, this event may not have been possible. I'd like to thank our team of researchers, trainees, and speakers today for their lovely presentations and the work involved in putting those together. I'd like to thank our Arthritis Patient Advisory Board for all of their work. They work tirelessly on this event all year long putting it together. And it's a big job, but they do a fantastic job. I would think you would agree with me. Lastly, I would encourage you also to go on to www.arthritisresearch. Sign up for our newsletter. It comes out 4 times a year, so it's not overwhelming in your inbox. And it's put on by this Patient Advisory Board, and there's amazing information in there and lots to learn. And what else? Facebook, Twitter. Also on our website, there's ways to give. So if you want to support the great research that you heard here today, there are numerous amounts of ways to give to that. Also, There is a feedback form on all of your tables here, and I suspect there's a way of giving feedback online for this event, and we welcome all comments you have to make this event better and bigger next year. And I think that's it for me. Thank you all for attending. I think that everybody online, in person, pat yourself on the back, because today you did something to make your healthcare better. Thank you.
Thank you so much, Shawneen. Wanted to remind you to fill out these forms on the table. We need the feedback. If there are any ways that we can improve this or something that we missed, let us know. We will not be offended. We will use it next year. We will now say goodbye to our webcast audience. Thank you for joining us. We hope you have enjoyed and learned from our 11th annual Roar. A final reminder to please fill out your online feedback forms and like us on Facebook. We love to be loved. We want your feedback so that future editions of Roar can best meet the needs of people living with all forms of arthritis. Please check back to our website, arthritisresearch.ca, as all presentations you have seen today will be available for viewing in approximately 3 weeks. Thank you, and see you next year.